Alors, continuons par la session. C'est une session interactive avec les participations de la salle et les participations d'experts en chirurgie mini-invasive du pied. Pour cette session, nous invitons nos experts à rejoindre le podium. Olivier Lafenêtre, Olivier, rejoindre le podium. Pet Mangon, David Redfern, Ali El Kouhen, Ali, il était là tout à l'heure, et Marius Uskatu. Pour cette session, nous vous demandons de vous connecter à l'application du congrès. Pour ceux qui n'ont pas encore le code Wi-Fi, il s'affiche devant vous. Ça va être sous forme de cas clinique. On va vous poser des questions à fur et à mesure et on va essayer de faire participer nos experts. Ali, il est là. Bien. Alors, on commence avec le premier cas. Donc, c'est une femme de 79 ans qui souffre de griffes d'orteil du 2e et du 3e rayon avec des métatarsalgies de tout l'avant-pied. Elle a plus mal à droite qu'à gauche. Elle est toujours active, elle ne fume pas. Bien sûr, à ce stade, on a besoin d'une imagerie. Et nous tous, on va demander une radio. Est-ce que parmi les experts, il y a des examens complémentaires que vous demanderez dans ce cas? La question posée à Olivier, par exemple. Est-ce que vous avez le micro? Est-ce que la régie peut allumer les micros?
No.
C'est bon.
Just X-ray.
Marius?
X-ray.
David?
X-ray.
Pete?
X-ray.
Ali?
X-ray.
The same X-ray.
Donc, pour ce cas, vous ne demandez que la radio. Vous avez la radio qui est devant vous. Est-ce que l'un de nos experts peut décrire ce qu'elle a? Ben, vous voyez qu'elle a un hallux valgus très important avec un supradictus du 2e et des griffes du 3e.
Il faut préciser qu'il y avait une allomégalie du 2e aussi.
Oui.
Donc, ça doit être un pied grec, je pense aussi. Bon, voilà, une petite déminéralisation osseuse.
Parfait. Et là, de l'arthrose au niveau de l'articulation métatarsophalangienne du premier rayon.
Marius, comment tu le lis? Tu rajoutes quelque chose?
Non, il n'y a rien rajouté.
Non? Très bien, on avance.
Alors, cette patiente, elle a mal, elle a très mal. Vous vous rappelez son avant-pied. Et donc, il veut se faire opérer. Et là, c'est une question à la salle. Donc, vous vous connectez. Vous avez la question numéro 1 sur votre application. Et vous répondez, vous cochez la question à laquelle. Le password, c'est question 1. Le password, c'est 1. Question 2, le password, c'est 2. C'est simple. Alors, est-ce que vous opérez en percutané, en mini-open ou en chirurgie classique? En attendant, voilà. En attendant la réponse, Marius, est-ce que tu l'opérais en voie percutanée, par exemple?
Moi, je fais toujours la chirurgie hybride.
avec while du 2 et 3 et 2 mots du 4 et 5. Et
Alors,
mini
on
ouvert.
ne parle pas encore de la technique, on va parler après de la technique. Est-ce que tu opères? Donc tu ouvres le premier rayon, c'est ça? En mini open.
Mini open.
Ok. Et les rayons latéraux, tu le fais en percutané.
Mixage.
Mixage, d'accord. David? In percutaneous surgery, mini invasive?
Does she have any pain from the first MTPJ, from the arthritis?
Yes.
She has pain from the arthritis?
Yes.
Mixed.
Mini open?
Well, if she has pain from the arthritis, I would do a first MTPJ fusion and then maybe percutaneous.
We'll speak after about now only mini open or percutaneous. So mini open.
Mini open.
Okay. Can we have? On n'a pas encore la réponse?
I agree with if she has pain at the hallux MTPJ, I would fuse that with a mini open procedure, and then the lesser toes I would treat with percutaneous techniques.
Alors nous avons la réponse. Alors pratiquement pas mal de personnes qui opéraient en percutané. Les 3/4 à peu près opérés en mini open et chirurgie classique pratiquement le 1/4. Donc là, on avait commencé à discuter sur ce qu'il y a à faire en posant. Donc voilà, on pose une deuxième question à la salle sur les techniques. Pour ceux qui optent pour le percutané, et vous êtes nombreux, qu'est-ce que vous ferez? L'ostéotomie de revers d'un Hicham, le chevron, le scarf, biseau, la pédus, basale ostéotomie, l'arthrodèse de la métatarsophallangien du premier. Est-ce que vous ajouterez une ostéotomie de Oiken ou pas? Pet Mongon, yes, you were speaking about what you do for this case. Pet?
For myself, the first ray I would do the MTPJ fusion.
Yes, excuse me?
For the
Fusion. Fusion for the first.
Fusion for the first ray,
first.
yes.
In percutaneous or mini invasive?
Mini open.
Mini open. Olivier?
MTPJ fusion percutaneously and percutaneous procedures for lesser ray and second and 3 toe.
Okay.
Percutaneous surgery.
Ali?
I will wait for the fusion. It's not a big or severe arthritis of the MTP joint. So I will do, as I usually practice, Hicham Rivadin plus Aiken osteotomy and correct the second toe.
OK. Donc la salle, pratiquement 30% qui feront un chevron en percutané. Pour l'arthrodèse de fusion, il y a seulement 10% qui feront la fusion. Alors que nos experts, donc aussi, Marius, tu es d'accord pour faire une arthrodèse?
Moi, je fais un mini open long chevron.
Chevron.
Yes.
Donc David, Petmangon et Olivier, ils sont pour une arthrodèse. Fusion.
She's
Yes.
79. She's 79
She's 79.
with a painful joint. So
79.
Fuse it.
And
I do rarely arthrodesis, very rare in my practice, but here I think it's the only one indication.
And Marius, why you don't do fusion?
Because in our hand, in my hands, these conservative surgeries work very good. I have
Even
a good results for me.
79 years?
Yes, maybe 86.
My experience with 79-year-old patients in the United States is they want one operation.
Yeah. And the nice thing about doing a fusion of the first MTPJ, and we may be coming to it, is that then I'm happy doing DMMOs with it. And one operation, I'm sure I will get rid of her metatarsalgia, or as sure as I can be.
Okay, so I will give you what the surgeon has done. Percutaneous fusion and percutaneous arthrodesis of the first metatarsalophalangeal for the first try. And for the other eyes, divergent domo for the second try, and DMMO for the third and the fourth, and soft tissue, and P1 osteotomy for the second, the third, and the fourth. Are you agree with this surgery? Our
Heidi?
expert.
Heidi?
Tu es d'accord pour cette
Yes, the result seems good.
Alors, tout ça, ça a été fait en percutané. What do you think about the fusion of the first metatarsal and percutaneous mongon? We can do it in percutaneous. Yes. So, after 4 months, you have the results, the clinical results after 2 years.
It's
Good
nice.
results. Yes,
It's nice.
it's nice. Any comment? Any comment?
Very nice.
Very nice. Yes.
Does she have any pain underneath the fifth metatarsal head?
No.
Because she has a little bit of a supinated foot on the original X-ray. And
No.
Okay.
No. Est-ce qu'il y a des commentaires dans la salle? Non. Ben, elle était tellement... Yes?
Can I just ask a question about that last one? Because you got
Yeah.
a very nice correction of the second toe. And was that achieved purely through... I saw a P1 osteotomy and a distal metatarsal osteotomy, and then you've relied on the tendon pulls to bring the toe straight, or how did you achieve such a nice result?
Just with the divergent domo, the
Domo?
P1,
Yes.
Precisely. So
because you correct the axis with the divergent domo.
I thought that's what you'd done, and it's interesting because that's what I've learned to do through the P1. So I do an oblique osteotomy there, and you're doing the same thing through the distal metatarsal.
Yeah.
But it was nice results. She was so happy that 2 years later, she comes for the other foot. It's the same pain, hallux valgus, supraductus of the second one, and hammer toe. And the surgeon do the same thing, percutaneous metatarsalophalangeal arthrodesis, convergent domo for the second one, DMMO for the third and the fourth, soft tissue, and osteotomy of P1 of the second, third, and for the osteotomy of the P2 of the fourth. And you have the result clinical, 2 years for the right, left, and 3 weeks for the left one. It's very nice. Good results. All that was done in percutaneous surgery. Any comments from our experts? No, it's good. Very nice. Okay. The second case. It looks like the first one. A woman, younger than the first one, 52 years, with pain, metatarsalgia, second, the third, and the fourth, hammer toes for the second and the third, and tyrobinion We need X-ray. You have the X-ray. Question for our expert. Can you come back? Yes, I come back.
Marius, 52 years old. What do you do? 52.
I am conservative for MTP1.
And what do you do?
Chevron scarf extreme.
David, conservative or fusion?
Oh,
Conservative.
yeah. I would, percutaneous, I think the question was. Yes.
Percutaneous?
Everything.
Yes. Okay.
It's a splay foot, we would describe it as.
Everybody is agree with conservative treatment? Olivier?
Yes, conservative.
Yes. So, percutaneous, mini open or classical surgery? We can obtain the reduction of the first by percutaneous surgery?
Yes.
Yes. And what technique you do? Question to everybody. Question 4. For the first try, what you choose?
I don't know why you're asking the question. It's obviously a chevron. Obvious.
Réverdin Hicham, chevron, scarf, biseau, lapidus, basal ostéotomie, MTP, joint arthrodesis. Est-ce que vous associez échinostéotomie ou pas?
It is the fourth question.
The third. It's the fourth. Hicham? And for our expert, what you do for this? In percutaneous, what technique you do? Olivier? For example, qu'est-ce que tu fais pour ce cas en percutané? Chevron?
Can you go
Yeah.
back?
Voilà.
I think you have to correct the adductus of the second. So, metatarsal osteotomy for lesser race with a divergent aspect. So probably Domo 2, 3, 3 not necessary, but for the second, sure. And you enlarge interspace between the first and the second, so you can push the head by 100% and perform a XL perc or a Mica, for example. And after you correct à la carte the toe and the fourth probably. So.
I completely agree. This is one of the very few indications I have for combining hallux valgus correction with DMMOs. Works really well, or of some form, but you have to here.
Marius, tu es d'accord avec eux?
Moi, je garde, I want to avoid tenotomy. I don't like tenotomy.
Pourquoi?
For this, I perform wild osteotomy for 2 and 3 metatarsal bone, and 4 or 5 and 4 convergent double Domo.
Double Domo. Okay.
Okay, but how do you correct hammertoes if you don't perform tenotomies?
By shortening of the metatarsal bone.
And is it enough?
This is my opinion to
in your hand, it's enough. Okay.
Opinion to avoid the tenotomy. I don't like the tenotomy. We want to keep the force of the toes.
Okay, but it's you preserve the longus flexor tendon, and if you cut extensor at the apex at the top of the joint, MTP joint, there is no problem after. No?
I performed this 200 times, and I'm stopped.
Pete.
I agree with you have to get the second. We have to do something to the second to move it over. Otherwise, you will not be able to move the head over far enough with a percutaneous chevron, Mica type procedure. And then you would need to do 4th and 5th DMMOs to correct the splay the other direction. And the third, I think, is neutral. And then, of course, various P1 osteotomies and flexor digitorum brevis tenotomies to correct the hammer toes.
OK. La salle, ils ont opté presque les 3/4 pour un lapidus. Alors, ce qui a été fait par le chirurgien, c'est un mini-scarf par mini-open, DMMO 2/3/4, Ekin, exostosectomy of the fifth try, osteotomy P1, second, third and fifth, and soft tissue ténotomie. C'est une patiente qui a été opérée il y a longtemps, avant que Marius met au point les domos. C'était au début. Qu'est-ce que vous pensez de ce résultat?
Do you have a recent X-ray or only this one? Do you have another X-ray
Yes.
after? Yes.
After, yes. We will show after another X-ray. Alors, ça fait peur de voir ça, par exemple. Ce déplacement du deuxième vers le premier. Voilà le résultat clinique à 2 mois. Et voilà à 2 ans. Et donc, vous voyez, même avec le démémo, ce dont on avait peur, il a bien consolidé. La patiente, elle est contente. Mais il persiste un trouble de rotation de la première phalange qu'il fallait peut-être visser dans le temps. Voilà. Oui, David.
It looks lovely. Would you agree that you have to have nerves of steel to coach the patient that it will heal? And it swells for a long, long time, doesn't it?
Yeah.
So do you have, I like putting them in a boot after this. Have you any experience of doing that? Because I find it really dramatically speeds up the healing. And it makes sense to me because it's trauma, it's a fracture.
Ici? Non. Et simplement un dressing for percutaneous surgery. C'était quoi la question? Olivier, c'était quoi la question, s'il te plaît? Est-ce que je mets une boîte plâtrée?
No. It was just a comment about our proposition with the domo, divergent domo, but the nature was very good in such a case. So.
OK. Et on passe à un autre cas. Tiens.
Samir?
Oui.
Oui.
The audience?
Vas-y.
Ah, il y a une question. Yeah.
Could you show the first X-ray before operation?
This?
Before, preoperatively.
Ah, you want to take a picture?
Yes.
Thank you. Any comments? Our expert for that? Tiens.
The present X-ray, you don't have no X-ray now.
2 years after.
It's 2 years
after.
now.
Yeah.
It's a long time. This is the
2
last.
years, the last one, yeah. We go for the third case. 46 years, man, do sports, mechanical pain of left foot for 3 years. Maybe he had a trauma of the big toe. He had corticoids for 3 times. He feels well after for a while, but now he has pain walking and he can't walk more than 300 meters. And you see the mobility is quite well. You see that the left foot, the range of motion is limited. Then, for this case, what do you ask? More than X-rays, do you need something?
No,
Ali?
X-rays is
X-rays, Olivier?
sufficient.
Someone, something else? Nothing?
White bearing,
Nothing.
X-rays.
Well, here are the X-rays. How do you classify? Which classification do you use, Olivier?
Yes. Well, between 2 and 3, yeah.
2 and
Because
3?
there was staphylitis.
Okay, 2 and 3.
It's an index plus minus.
Plus minus, okay. Something else to say? Nalux rigidus? Okay. Well, we have
with dorsal ossified, as you can see.
Yes, you can see it.
And lateral side.
Someone in the audience will use something, another examination? No? Nothing? We continue?
Is there pain at
Sorry?
pain at mid-range of motion? Yes or no?
Main?
Pain with mid motion, not in
Mid-motion.
middle range of motion.
Not a lot.
Okay.
Not a lot. It's like an arthritis. So, after a while, the 300 first meters are well, but after, pain. Verichman, then he had a CT scan. Is it useful? Pete, David?
I didn't understand what is it. If it's useful.
Do you ever ask for a CT scan for these cases?
For me, no.
No.
It's for me more important clinically. Do they have pain underneath in the sesamoids? Do they have central pain, or do they use their finger and say the pain is just here where the bump is? For a kylectomy, which is I think where we're going, they must say it's the bump only, really.
Okay.
Anybody else? Any comments?
I use Coughlin's
Classification.
criteria. Well, just his indications were that if the patient only had pain with the upper level of dorsiflexion, then kylectomy was okay. But if the patient has pain with just a little bit of motion, then a kylectomy is not as reliable.
Okay. What would you do? The audience, do you do a non-operative treatment? Maybe he waited a lot. A percutaneous treatment? An arthroscopy treatment? A mini-open treatment? Or classical surgery? Is the question 5. You try to answer. And waiting for the audience. We wait. You can. It's okay. The 5th question. Non-operative treatment, percutaneous. Already. We're good. Then classical surgery. I think is a good option. Then mini-open. Okay, mini-open or classical surgery. What would you do for these, our experts?
Are we allowed to have 2? Can I do percutaneous and arthroscopy?
You can.
Mini open.
But for every time for Alex Residus, you do that?
No.
Why you use arthroscopy?
Okay, so it would be clinical decision. Is the joint very irritable? More so than the x-rays suggest. So with a grade 2 that the patient's going, oh, really hurts, mid-range, I think there's often a lot of synovitis. And so I will do the kylectomy, percutaneous, and put the scope in and look and remove the synovitis. I don't think it makes any long-term difference, but it means they recover quickly and back into their shoes. And there's nothing worse than doing what was supposed to be a quick operation and the patient not recovering quickly.
Okay. Marius?
I would normally do percutaneous, but I make an extra incision in the web space to form an outflow portal, and then I aggressively flush all the particulate matter out of the joint. So I make a small incision just to the lateral side of the MTPJ, open that portion of the capsule rather than using an arthroscopy to do the same thing.
Okay. Olivier?
Normally, in the case of an index plus minus or plus, I do mini open while to shorten the metatarsal with a chelectomy effect. Probably in such a case, I use this procedure, but like David, I examine the patient, and if really has a pain only on the bulb, probably chelectomy and synovectomy in an arthroscopic way. But
And if, yeah, vas-y Marius.
For me, the problem of this case is the decrease of intermetatarsal angle. And I perform spatial osteotomy, reverse chevron osteotomy for increase the intermetatarsal angle and shortening the metatarsal bone. Shortening and increase the intermetatarsal angle.
Okay. Then the surgery, for this case, there is dorsal chelectomy or wide osteotomy. And Ali, what do you do?
I will do in this case dorsal chelectomy to remove the osteophytes, and after I will do osteotomy, dorsal osteotomy of M1 to move the cartilage in the front of the P1. I will stay conservative.
Oui, Olivier?
so I had generally a Moberg osteotomy to enlarge the superior part of the joint, combined with the EDL tenotomy to reinforce the FDL. When I use either chelectomy or wide osteotomy.
Sophie? I will show you what have been done. Here you are. What do you think about it? There is a wire with an aching, screwed, both. What do you think?
It's very nice. I think it's very nice. Can I ask you a question?
Ask.
What are your indications for doing a shortening vial of M1? Because I like the operation. I use it in a small number who are long, obviously plus in their first metatarsal. But two things I don't fully understand is how much length do I need before it's safe to shorten a bit? How much to shorten? Actually, it's three things. When and how much to shorten? And the third thing is what angle to make the cut. I make it 45 degrees. I don't know whether I can make it flatter, steeper.
It's a good questions. Pete,
Sorry.
can you answer?
I am not an expert on that operation at all. In the United States, that is an operation that is frowned upon and is not done very frequently. So I have not done that. I would normally do a chelectomy and a Moberg or an Aiken. Moberg, Mo-Aiken type, just to, by shortening P1, take some of the pull of the tendons, and then that seems to work.
Olivier, it's your idea? Pardon, Pierre. I said.
I have a great big experience with this osteotomy, and that's true. The angle is changing because it depends on the profile view. If you have a K foot, you will make your cut more horizontal, and if you have a flat foot, you will be more vertical. But in this case, you cannot shorten a lot. You shorten like this. You have to be. You don't have to have a metatarsalgia after. So you can have 3, 4, 5 maximum of difference between the first and the second, not more. So you have to check before and to count how much.
Okay. Any comment? that 2 years after is doing well, no pain in the first tray, and in the lateral raise, no pain. Here, the result is not bad, maybe very good plantar flexion. And here, something strange. You see the flexions of the toes, right toes. There are different. You see here? The flexion of the toes are different here. We don't have the same because we have shortened the first tray. But no pain. That's what we wanted.
He is the patient, and the surgeon is Olivier. Okay. The first case, un autre cas, c'est une autre utilisation, peut-être, de la chirurgie percutanée. C'est un infirmier de 60 ans, toujours actif, qui a un diabète, ce n'est pas un pied neurologique, pas de problème neurologique. Depuis 1 an, il souffre d'un ulcère chronique avec intermittente et des infections intermittentes au niveau sous la tête du 2e et du 3e tête métatarsienne. Donc il a essayé tous les traitements, les semelles, ça ne marche pas. Il n'y a pas de problème vasculaire. Qu'est-ce que vous pensez? Par quel moyen on peut traiter, voilà la radio, vous l'avez devant vous, par quel moyen on peut traiter ce cas clinique? Donc c'est un tableau d'un ulcère au niveau de la plante du pied. Ce qui le dérange, c'est plus l'ulcère, il n'a pas très mal. Question à la salle, est-ce que vous opérez ce patient en percutané, en mini-open ou en chirurgie classique? Et quelle chirurgie par exemple? On en parlera après. Votez pour ce cas clinique. Et je pose la question à Marius, qu'est-ce que tu ferais pour ce patient?
I don't know.
Tu es en train de penser. Ou bien tu vas l'adresser à l'autre chirurgien.
What we do.
David, yes, David?
I'm going to do 2 again. Every diabetic patient in this situation with a forefoot problem will get a calf release. They'll get a gastroc recession. Every patient. I won't take them to theatre without doing a gastroc recession. But I would do percutaneous. And my thinking at the moment, no infection?
At the
Maybe,
moment, no infection. No.
No?
No.
I think probably I would do it percutaneous, DMMOs, and I probably would make no attempt to reduce the dislocation. He's not complaining of that.
You
so
let the dislocation like this. Okay. Olivier, are you agree?
I will do converse demo.
DMMO?
Converse DMMO.
Converse DMMO?
To elevate.
The second, the third, and the fourth.
Second, so every metatarsals.
And you don't touch the dislocation?
No.
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 Okay.
And PRF membrane. PRF membrane.
PRF, yes.
For the ulcer.
I will do the same.
Pete, you will do the same, Ali?
Wait, yes, plus gastroc recession and no weight bearing.
And Pete?
I agree, whether it be gastrocnemius or Achilles, one or the other, some sort of Achilles lengthening, and then the percutaneous DMMOs, and then you might need to do a osteotomy at P1 on the second to bring it down a little bit, because it may sit up over top of the first ray still, or still sit a little high.
Ostéotomie de P1 pour abaisser. OK. La salle, est-ce qu'on peut avoir la réponse de la salle? Alors, la salle aussi, donc il est comme nos experts, c'est en percutané. Tu veux poser une question?
Achilles tenotomy or gastrocnemius release, you do it for that? Both. Yes. Pete and Ali, why?
Yes.
Yeah.
Because in my experience, the vast majority of these patients have Achilles contracture. And you could do it without it, but, and it would probably improve, but long term you would end up with additional problems as that Achilles contracture worsened once again. So I think lengthening the Achilles improves your longevity of your bony work.
And does it change your postoperative care if you do it simultaneously?
No, I let them
full
weight bear.
bearing,
Yeah, I put them in a cast, and I let them weight bear.
Okay.
Correct.
And I have visited last year Dr. Laborde from New Orleans, Louisiana. He had a big series of these kind of lesions, and he always do the gastric recession for this kind of lesions, and he has a good results. Maybe one day I can present to you that.
Okay.
And you will do it operatively or percutaneously, or open or percutaneous?
Percutaneous.
The release of the gastrocnemius.
Oh, the gastro. I do a small incision medially and actually I use a speculum, and use it as an endoscope basically and go across.
Marino, you want to tell something?
Yeah.
Yes, the endoscopic release of gastroc and soleus, it's okay. And the MMO, so. But just don't forget one thing. You haven't spoken about the vascular status. He has a neuropathic foot, and but to operate and to heal, he must have also a good vascular status. If he has one good vascular status, we can do the DMMOs, but we risk the shark of foot.
Yeah.
So just be aware of both situations.
Okay. Okay. So, like our expert, it's what our surgeon has done for these cases. It's not like the memo for the second, the third, and the fourth, more proximally. And you have any comment for this, David? Yes, you want to comment something?
I'm sorry, Marino just made me think of something. So, Marino, if the vascular status was awful, what would you do? Would you excise the metatarsal head instead of doing an osteotomy? What would your solution be?
No, I would ask to the vascular surgeon or to the angiologist to make something like a stent or something possible. If the vascular state is not good, you will probably end with a mid-tarsal amputation.
Okay.
You wouldn't try, Marino, this percutaneous because he has a long time with this ulcer, and you wouldn't try to do it? In our country, it's very hard to propose the amputation.
Yeah.
They don't let you amputate until it is very late time.
Yeah, naturally it's like that. But no, what I would say is that in this situation, I suppose he has not a bad vascular status, and the ulcer is due to the pressure, to the load, to the overload of the dislocated toe with probably the gastroc. So if you do the endoscopic release of the gastrosoleus and then you do the DMO, it can be okay, sure, because you take off all the mechanical aspects. But don't forget that mechanics is not the only one. The other part of the couple is the vascular status. And if you have a bad one, you can do whatever you want. You will simply delay the infection and the amputation necessity.
Marius?
For this, I try the first to healing the malperforant by using post-operative shows, the Baruch, for 2-3 months. We have a chance for healing.
Il a déjà essayé, ça n'a pas marché. I tried everything before surgery. Yes, Olivier?
You can see that the surgeon performed more proximal osteotomy.
Yeah.
It's not DMMO.
No, it's
to
not the memo, it's
obtain
osteotomy of the first, the second, the third.
to
It's
have
not
a
system.
more level harm, but with the converse DMMO, more distally, you
More
can obtain
distally,
the
yes.
same elevation, and it's more stable for the for healing, bone healing.
You have the results
Oh, okay.
6 weeks after,
Yeah, looks good.
and it's good results.
It looks very good. I wanted to make one comment about the gentleman mentioned neuropathy. First of all, most neuropathy not neuropathy, Charcot. Most Charcot occurs in hypervascular scenarios, not dysvascular scenarios. But I do think it's important that in all of these patients, I do have that conversation with every one of these patients that if I do percutaneous DMMOs, that there is a possibility they could develop Charcot complications. And I think that's important that people mention that to the patients should that occur.
Okay, any comments in the audience?
I'm a little bit afraid that maybe it will be the recurrency of the same problem because the problem about the second dislocation wasn't resolved for the moment.
At the moment is good, perhaps.
Cross the
Yes,
fingers.
David?
I think it looks really good, and I think
It's very good
it's a good
results.
solution. I'd
And-
be delighted
And
if the
no
foot looked like-
pain, he work.
I missed, did you
He's
say,
farmer, he work now. He has no pain. It's good.
did you
We
do
will
a,
see after, perhaps.
did you do a calf release? I missed, did you do something to the Achilles or the calf?
No,
Oh, okay.
On the second toe,
no,
nothing.
nothing.
Don't have transfer metatarsalgia in fourth metatarsal,
Perhaps.
because I present this for converse DMMO.
Then you can do your calf release.
Okay. Case number 5. A woman, 76 years old, metatarsalgia, the second and the third one. He has done resection of the head of the second and the third with arthrosis for the first métatarsophalangeal, for the cuneo-metatarsienne and talar bunion. You have the X-ray. First surgery, resection of the head of the second and the third. And he has arthrosis here. Cuneo-metatarsienne. Question to the audience: what kind of treatment you do for this patient? Non-operative treatment, percutaneous surgery, mini-open, or classical surgery? Please vote.
And send to the experts.
Yes, we have a question.
Arthrosis of amidine, cuneiform metatarsal cuneiform, symptomatic, painful or not?
What?
The question is
The
arthrosis between
Asymptomatic.
metatarsal bone and cuneiform bone. Asymptomatic or symptomatic? Pain or pain-free?
She has metatarsalgia, more metatarsalgia than pain in the arthrosis.
Pain in arthrosis?
Pain, yes. En attendant la réponse de la salle, on va poser une question, on va réveiller Michel. Michel Maestro, je viens. Voilà. Qu'est-ce que tu ferais pour ce cas? Je vais te réveiller. Tu viens d'atterrir.
It's a case of revision surgery, and we have the rule of the shorter ray, and I think in this case you have to relieve the pain on the C1-in1 joint, of course. You have to solve the problem of the hallux valgus, and you have two options, in fact. you can do an arthrodesis of the first ray and silicone arthroplasty second free. It can work. Or if you want to stay conservative, you can do a scarf, shortening scarf osteotomy, nothing on the second and the third, or perhaps a little DMMO because there is a metatarsalgia on the sole, and DOMO on the 4th and the 5th in order to have a new tensegrity equilibrium of the forefoot.
Any comment with our experts? No. Barbara, yes.
I have the same case. I did the same case. For the pain in the...
Reviens à la diapo, s'il te plaît.
For the pain in the first metatarsal cuneiform, it's not really the problem. If you have osteophytes, you just burn the osteophytes and you shorten your metatarsal. So I like conservative treatment. For the first ray, it's not really the discussion for me. In the case I had, I cut the metatarsal 2 and 3 and put Interflex, silicone prosthesis, and I did DOMO of the 4th. And it was a very good result. What is the age, please?
She's 76.
The girl I operated, she was 44 years, but I did that, and I had a good result.
Any comment? Yes, Michel?
Yeah, just a precision. I agree with the silicone arthroplasty in salvage for the median raise, but the problem is for the long term. Yeah. If you cannot protect your central ray with an arthrodesis or very strong first ray, the risk is to have big problem after some years on the middle of the foot. And I think if you choose silicone arthroplasty, try to do the arthrodesis of the first ray.
The first ray.
It's documented and in the literature is like this.
Alors l'audience, ils sont pratiquement, tout le monde a choisi toutes les techniques. Oui?
What I would like to know is why does she have pain in this MTP2 and MTP3? It's just due to the load, like a metatarsalgia transfer, but the first ray is long. Okay, maybe she has a rigidus. What is the cause? Or just is it due to the arthrosis of the joint? It is due to the arthritis of this joint? Why does she have pain in these two joints?
C'est la réponse.
What do you think?
No.
Olivier.
Marius, c'est lui qui va répondre.
I cannot speak because it's my case.
Yes, we know.
So it could be the first ray could be unstable and elevated and putting more pressure on the 2-3, even though the 2-3 heads are resected. I think sometimes I worry about a neuroma where those metatarsal heads have been removed. There's scar tissue, and some patients will get a postoperative neuroma in that area that sometimes resolves actually with a simple injection. This would be one of the unique areas I would probably get a CT scan, whether it be weight-bearing or not, to see if there's bony overgrowth on the plantar surface of where the metatarsal heads were resected. And I have seen that before, where you resect a metatarsal head and then they get plantar overgrowth. And if you just go in and take that exostosis off, those symptoms will improve as well. But I definitely think at least the 4th and maybe the 5th, I think you need to do a DMMO on that to reduce the stress on that area long term.
I'm with Pete on that one. She's 76, she's had failed surgery, very high stakes with the midfoot arthritis as well. This is a good indication for a standing CT.
Yeah. Okay. The surgeon has done chevron, big chevron for XXL hallux valgus, echin of P1, domo of the second one, and while for the third and the fourth, and triple domo of the fifth. Vous reconnaissez le Marius là-dedans. C'est le cas clinique de Marius.
Why
He's
did you
the
choose
surgeon.
that, Marius? Why did you choose this technique?
Can you explain your choice?
I'm choosing to conservative treatment for M3 and to harmonize the length of all metatarsal like Maestro Criters, not more. And I'm choosing the conservative treatment for the first metatarsal phalangeal articulation because I have a good range of motion. Don't have pain in this articulation.
Any comments? Yes, Barbara?
Marius, I have a question. There was no more head in the third at the beginning. Can you go before, please?
You will see the evolution. The actual.
So you did a whale in the neck.
You will see the evolution.
No.
It's not the last X-ray.
But can we see the X-ray before, please?
Yes. You have no head in the second, and you have done in the third, and you have done while.
You have a head. You have a head in the third.
In the third.
A little bit.
A little head.
You will see.
Okay.
You will see the final X-ray for entry.
She has.
I would just, excuse me, I would just say another thing to Michel. For me, silicone or alignement, like here, it's the same. So if you leave the alignement and it's like a silicone, so in this fact you have to fuse the MTP1, but you have an arthrosis in M1C1, so it's not a good choice for me. Okay.
Okay. Any comments before the results? Our expert? No? Okay. And you have the results of this case.
Look at the head of the third metatarsal bone.
That's magic.
So she has head.
But the second ray is very short.
Yes, but don't have more metatarsalgia because I perform osteotomy, domo oblique metatarsal osteotomy.
I think the rest of the world has more vitamin D and calcium in the water they drink because I don't think anybody in America would heal all that.
Est-ce que vous avez d'autres commentaires, Olivier?
No. Perfect.
Non? Parfait.
Marius' signature.
Marius' signature, yes. Okay, it was the last one, but Ali, he has another case. He will present it. Yes, Ali. Thank you for your participation.
Okay, if you have a few minutes more with me, can you give me your attention? So, I practice minimally invasive surgery since more than 10 years, and I begin by easy cases, and now more cases, more difficult cases. I use Hicham Reveda technique, and now, what's your opinion about this case? This is a case with bunion with rheumatoid arthritis, as you can see. This is a woman, 46 years old, and she has a bilateral deformation of her feet. I didn't find the right foot, but you're going to see after. So, this is the X-ray. As you see, you observe there's a huge alex valgus with dislocation of the second, third, and fourth. So I leave you 1 minute to think about it. Okay. what's your opinion? And what do you propose for that case? Implantatoplasty, fusion, chevron, scarf, others, converse domo, and after what do you think, what are you going to do on the lesser toes? Head resections, fusion, others. Okay. In the audience, do you have an opinion about that? I operated her 6 years ago for the right foot. And after this year, I operate the left foot.
So we see, in the UK, we don't see this severity very often now because of modern medical treatment.
Exactly.
But she's 46. I'd want to preserve as many of the joints as I could.
She has...
So, number one decision. My personal preference then would be to do it all percutaneously.
Yes.
And probably percutaneous chevron. And DMMOs and correction of the lesser toes percutaneously as well, I suspect.
Okay.
I am for conservative treatment, like Baroque technique, shortening of all the 5 rays. I have only 40 cases like this.
I'll be the heretic. I would probably fuse the big toe at this point. I think part of the reason is it's the disease that's causing the problem, not just the deformity. So you have a synovitis issue that occurs that results in the breakdown of the ligaments, and so ultimately her end result will be fusion of this joint. And certainly you could preserve it, but I'm not sure that I can preserve it well enough and consistently enough that it would be a good outcome on a regular basis. So I'd probably fuse the great toe, and then I would do percutaneous DMMOs and lesser toe corrections, because I think patients can tolerate the synovitis and the deformity better there over time, and you can improve the deformity with the percutaneous methods.
Can you correct the dislocation with only with DMO?
You can correct some dislocation, but more importantly, patients in my experience, the rheumatoid patients in my experience don't complain of their toes being dislocated, they complain of metatarsalgia. And if you just elevate those metatarsals or move them to where they need to be so that when they ambulate, they're not ambulating directly on the metatarsal head, which is dislocated, they seem to do okay. And you don't lose much with that. If it doesn't work, you could always come back and do metatarsal head resections if you needed to, and it would be a reasonable option.
So I'm probably more heretic than you, Pete, because the most important for me is the status of the rheumatoid arthritis. Which treatment she has?
She had rheumatoid arthritis since 20 years.
Yes.
And now she had a big pain on her plantar foot, and that's it.
She has steroid or TNF drugs.
Methotrexate, exactly. Corticoid.
For me, it's a fusion for the first and Baroque prosthesis. So it's a metallic prosthesis for the second throw, 3, 4, and 5. Because one operation only and it's finished, and we do it for over 20 years in Bordeaux with excellent results in the long term, even if it's a young patient. Yes. So no conservative treatment.
Okay, I'm going to show you. No comment in the audience? Barbara, tu veux dire quelque chose sur le cas de la polyarthrite? Here, yeah. Tu veux dire quelque chose avant de passer? Non. Michel, maestro? 46 ans.
Yes, but the problem is the status of the inflammatory disease. Here, few bone destruction of the head, but the problem is the retraction of soft tissue and the subluxation and the huge deformity. I agree with Olivier, one shot. One shot, it could be with first ray arthrodesis and the silicone arthroplasty, 2-3, and head resection, 4-5. And
I agree with you.
And if Tournai do the same for a long time.
Mainly in Morocco, because we have only one shot. We can't do many operations, that's why, surgeries. So I'm going to show you what I did. For the left foot, I do a fusion of the first metatarsal, how you told, and did shortening head metatarsals for the second, third, and fourth, with mini open surgery. I put key wires for maybe 2 months. This is controlled 2 months after. 4 months post-operative. And 6 months after, I remove the key wires and begin to move her toes. 4 years after. And today. And for the right foot, I did the same. Oh, yeah. Not only that. And now this is the last control, 6 years after. And she's happy, and no pain more, no more pain. No, I didn't touch the fifth. As you can see, the fifth is okay. So maybe for the rheumatoid arthritis, fusion is a good choice for the treatment. Thank you.
Merci tout le monde. Merci à la salle. Est-ce que vous avez des questions à poser à nos experts concernant ces cas? On a encore quelques minutes si vous avez des questions. Sinon, merci à nos experts et merci à tous.